great honor to be here with all of you, and I've been told by Dr. Keller that I had 12 minutes, so let's see, we're going to take this off and run. I don't know if any of you have been to Birmingham, but this is the city skyline and all the red brick buildings there in the foreground is the UAB campus. There's about 80 city blocks that are occupied by UAB in downtown Birmingham. This little cartoon illustrates stuff that I've been working on for the last 15 years at UAB. And you'll see in the middle of the figure a little circle that talks about life space mobility. In geriatrics, the practice of care of older adults, we really focus on what it is that people do. And you've already heard that that's one of the most important things in terms of caring for older adults, is helping them maintain an active lifestyle, be independent, and continue to do the things that they want to do. One of the most common areas that older people report difficulty in doing what they want to do is in the domain of mobility. Over the last 20, 30 years, there's been a fair amount of research in this area, but most of the mobility research in aging had focused on specific tasks, like do individuals have difficulty with walking, do they have difficulty with driving, difficulty with climbing stairs. We wanted to develop a measure that would allow us to capture the full spectrum of mobility that we see among community dwelling older adults, all the way from individuals who stay in their home and never go out, to those who travel wherever they want around the world on cruise ships or in airplanes or whatever they want to do. And so we worked on that, and this little picture shows all the different factors that could come to play in mobility. One of the factors you see on there is one of the focuses of the wonderful center that you have for this Institute for Dementia Research and Prevention, and that is the issue of frailty. And also, one of the things that we have felt is that we could detect early changes in mobility. We might be able to identify those factors that precede that change in mobility before more serious adverse outcomes happen, like having to go to a nursing home, becoming disabled, or even dying. So this little picture has been guiding our work. So what I wanted to do tonight is quickly define the concepts of mobility, frailty, and brain function and how they can be assessed, describe the relationships of mobility, frailty, and brain function measures among community dwelling older people, and give you some information about the implications of mobility on brain function. Now, this little cartoon here illustrates this concept of life space, and we envision one's mobility as these concentric circles that extend from one's bedroom to outside their city or town. And individuals who get stuck in their neighborhood and can't go out without help from another person would have restricted mobility in this framework. We've developed a little questionnaire that asks, how frequently do you go out of your house? Whether or not you need assistance, and whether or not you use any special equipment. And we've been able to develop a scoring algorithm that lets us quantitate this from a score of 0 to somebody who never leaves their bedroom over the last month, to somebody with a score of 120 that would go out of town every day without any assistance. So the higher the score, the more independent, more frequent, and the greater distance someone will travel. And we've actually come up with a categorization of these scores where someone with a score of less than 30 would really have very low mobility, and these individuals are pretty depressed and pretty discouraged about that, when individuals with life space scores of greater than 90 are probably like what most of you would have if we did this assessment on you, and you're out and about and pretty optimistic, pretty independent individuals. So that's how we measure mobility. Now, another concept you've heard about, and is a focus of this research center here, is the issue of frailty. Now, doctors frequently talk about older adults becoming frail, and they know that this is a serious problem because when frailty occurs, the individuals are more vulnerable to insults. So if somebody goes into the hospital, they may become confused and then afterwards have to go to a nursing home, or if they get in a car wreck, they get more serious injury than they would have had if they had been younger, or they take a certain medicine that when they were younger wasn't a problem at all, but now causes them confusion or maybe causes them to fall. And a bunch of doctors across the country were interviewed by a doctor by the name of Dr. Freed and asked, well, what do you mean by frailty? And she came up with these 5 categories of problems that these individuals all agreed was part of the picture of frailty. So people who are losing weight, we know that losing weight, and you're not intending to lose weight, is associated with a marked increase in risk of mortality for older people. We know people who report that they're tired all the time will frequently limit their activities. We notice that as people age, their gait will slow down. And we got a simple little measure where we can have people walk across the room and time the gait speed, and individuals that have the slowest speed would be more frail. Individuals who stop going out and about or have inactivity would be another characteristic of frailty. And individuals that might have trouble standing up out of a chair or gripping something with their hand might have decreased strength, and this would be another category of symptom. And this particular index for frailty, if you have 3 or more of these, you would be considered definitely frail. If you had none of those, you would be considered not frail. So that's how we've been studying this construct in the UAB study of aging. And then there are lots of ways to measure cognition, and I've got really lots of experts that I've met here at the Pennington Center who know a lot about measuring cognitive function. And many of you who have been in this wonderful study here know that you take tests that last 45 minutes in order to figure out how your cognition is. But in this UAB study of aging, we went into the homes, and cognitive function wasn't the primary aim for the study. We were really looking at mobility, but we saw cognitive function as being an important part of it. So we did a couple little screening tools, screening tests. And one of the screening tests we did was ask people to draw a clock. And we asked them to draw the face of the clock such that anybody could look at it and tell the time was 1:40. And then we used a scoring algorithm that was developed by Dr. Royal in the University of Texas, San Antonio, to score these tests. And these are some of the clocks that were drawn by the individuals who were 65 and above in our study at the UAB study of aging. And you can see some interesting looking clocks there. And what we have done is categorize individuals into 3 categories. Individuals who are able to draw the clock perfectly normally, just by us telling us. People who do that and can also copy a clock are normal. Individuals who can't do either one of those things, draw a clock freehand without anything to guide them, or copy a clock, would have what we call type 1 phenotype for this test. And that means that their characteristics are very similar to what you might see with somebody with Alzheimer's disease, that form of dementia. In the type 2 phenotype, the individuals couldn't draw their own clock without any help, but they could copy a clock. So their impairment wasn't as global as the type 1, so it's a less severe cognitive impairment. And this, those are the assessments that I'm talking about today. So we've got a mobility assessment, which is life-space mobility. We've got a measure of brain function, the clock drawing test, and also a little simple questionnaire, a 30-item questionnaire that we use. And then the other metric was the frailty metric, and if you had 3 or more of those conditions that I described, we described you as frail. So this particular study involves 1,000 Medicare beneficiaries aged 65 and above who were living in the state of Alabama between 1999 and 2001, and we recruited them for the counties that are highlighted there in the state of Alabama. And UAB doesn't have a very good football team, so don't really worry about that tonight. Okay. So we oversampled males, African Americans, and rural residents so that we would end up with a sample that were 50% male, 50% African American, and 50% rural. And that's what we ended up with. The average age was 75. And Alabama's a poor state similar to Louisiana, where 23% of our people reported total annual household incomes of less than $8,000, far below the poverty level. The average score on this life-space mobility score was about 65. And I wanted you to see this picture. And you might recognize some of these people. Maybe they're like some of your friends or family here in Louisiana. But these subjects all were participating in this research project. It's very important to have research participants, and I know Dr. Keller and his team appreciate all of you that are participating, and I hope that you'll consider joining their project here. They're finding very interesting, important things that will have great impact on the future health of your friends and neighbors here in Louisiana, just like this study hopefully will do in Alabama. But this just shows you the distribution of life space scores, and for those of you who are kind of mathematical or in concept, is this kind of has a normal distribution in that there were a few people that had very low scores and a few people had very high scores and a bunch of people in the middle that had kind of intermediate scores. And we found that this is true at baseline, and even after 8 years of follow-up, the distribution of scores looked the same. And this shows you how many people at baseline reported the different categories of frailty. So about a third of the people said they were exhausted. We found that 27% of the people could not complete the chair stand test that we asked them to do in the home, and so they had low strength. We had 20% that had 10-pound weight loss in the previous year that had been unintentional. 18% reported no walking outside the home in the previous 4 weeks. And then 10% could not complete a walking task in the home safely across the room. And so what we did again, if you had 3 of those characteristics, we considered you frail. So we found that 15% of our population was frail and 42% were not. And then 40% had an intermediate degree of frailty, so they might have had 1 or 2 of these characteristics. Okay, so I showed you the clock scoring mechanism, and you can see on this figure there were some people that were able to both draw a clock spontaneously and copy the clock, and some didn't do so well drawing the clock or copying the clock. People who couldn't spontaneously draw the clock but could copy the clock. So type 1 is the global dysfunction, like Alzheimer's disease, and this is a less severe kind of impairment in cognitive function. And we also did a paper pencil test asking, do you know where you are? Do you know what the day is? Speech questions, can you remember 3 items? Some of the tests that you guys have done, it's a 30-item test, and typically this test is considered normal if you score 24 or above, and you see that a bunch of our people did score. I'm sorry, I'm looking at the clock scoring scores, not the mini mental status. Anyway, we'll just go straight ahead. This is just a summary of the clock drawing test. This is the paper test. The green bars represented scores greater than 24. The purple bars here, I guess that's in honor of LSU, were 24 or less. Actually, it looks purple up there, blue on my screen, so I'm not sure what that means. Okay, so what I wanted to show you is how frailty and cognition related to mobility. And you see here, the individuals who had the lowest mobility, a score of 0 to 30, 2/3 of those were definitely frail. 1/3 was not. So there are 1/3 of people that aren't frail have very low mobility. And you can see the highest scores of mobility, the life space score, 90 to 120, only 1.5% of those individuals were frail. So about 98% of those individuals were not frail. So there's a very high correlation between frailty and mobility. And we also found a strong correlation and relationship between mobility and cognitive function. So the global dysfunction associated with the type 1 phenotype where you couldn't draw your clock on your own or you couldn't copy a clock, 2/3 of the people who were in the lowest mobility group could not, but 1/3 could. And in the highest level of mobility, 18% of the people couldn't do both of these clock drawing tasks versus about 80% of them could. And this shows you what proportion of people had both frailty and global cognitive dysfunction. And you see in the lowest category of mobility, 0 to 30, about 45% of people were both frail and had global cognitive dysfunction, but that means that about 55% didn't have either of those, but nobody in the highest mobility group had both frailty and global cognitive dysfunction. So there are relationships between these and mobility. Now, we've followed our sample of 1,000 community dwelling older people over 8.5 years. We called them every 6 months and did the life space assessment. And these curves show you how the life space score changed over time. And what we found is that in the normal individuals who had no evidence of cognitive impairment, they were able to draw both clocks. We see about a point per year decline in mobility with aging. And these are the individuals who had couldn't copy the clock, but couldn't draw the clock spontaneously, but could copy it. That's the type 2 phenotype. Look very similar to those who were normal. But the individuals who couldn't draw a clock freehand and couldn't copy it were started out lower, and they are more rapidly declining in their mobility. And the final little thing that I wanted to show you is we published a paper in 2008 on mobility, life-space mobility, and cognitive decline in a community-based sample of African American and Caucasian older adults. And what we found is the participants in the highest quartile of mobility had a 53% lower odds of substantial cognitive decline, and this was a 4-point drop on the paper and pencil test. And this association didn't relate to baseline cognition, age, race, sex, urban-rural residence, level of education, physical activity, physical function, vascular risk factors, or psychosocial factors. And so my psychology friends think that getting out in the world may expose you to complex situations and help your brain keep learning new things and protect against cognitive decline. An alternative hypothesis is individuals with early dementia might start withdrawing, and that's the reason why the mobility may be lower, and maybe the reason why we're seeing there's less cognitive decline in higher mobile individuals. So what are our conclusions from this presentation? There's a lot of variability among older adults in the community. 90% of people over 65 do not live in nursing homes. 95% do not. And most older adults are very highly functional. Most older adults are not frail and not limited mobility and not cognitively impaired. But with aging, the proportion does increase dramatically. And our goals, and the Pennington Center's goals, the Institute for Research on Dementia and Prevention of Dementia here at Pennington, are all working to try to how to keep us all successfully aging. That's really important to me, and I think it's probably very important to you all as well. High levels of mobility do predict maintenance of brain function, so we all need to keep moving.